Good afternoon, everybody, and welcome to Session 2, Clinical Management of HIV. My name is Gary Rubin. I'm an assistant professor at the University of Toronto in Canada, and I will be chairing this session. Before we begin, as you all know, this meeting was supposed to be held in Paris, and I learned this morning that Paris and much of France may be going into a lockdown today or tomorrow. So I just want to say our thoughts and prayers are with everybody in France, and I hope you all stay safe and healthy. We have some exciting presentations. We have 2 oral presentations and 3 abstract presentations. We will have a question and answer period at the end of the last abstract presentation, and I encourage everybody in the audience to submit your questions via the chat, and hopefully we'll be able to answer everybody's questions. So our first speaker this afternoon is Dr. Martin Duracinsky. Martin is the group leader of Paris Diderot University. His research interests are patient-reported outcomes in HIV and hepatitis, and he'll be speaking about patient-reported outcomes and current studies. So, Dr. Duracinsky.
Hello, everybody. So I'm going to present you today the role of patient-reported outcomes in HIV studies. What is the regulatory place of patient-reported outcomes? Before, quality of life and patient-reported outcomes was considered as the soft endpoint, and the data was not of very good quality. The studies were more something like fishing expedition. The situation really changed now. We do really have a high standard for methods how to measure patient-reported outcomes in clinical trials. And we have more and more claims that are validated by different health authorities in clinical trials. These slides represent different endpoints that can be measured in clinical trials. And they go from biomarkers, clinician-reported, observer-reported, but what we are interested today, what I'm going to talk about, is patient-reported outcomes, and then can go from simple like symptom, function, perception to the multidimensional quality of life. What is the definition of patient-reported outcomes? It is about patient perception, and it's important that it's really scored by patient himself or herself. And the measures can be ranging from a single item to a multi-item tool. And these multi-item tools can be unidimensional, measuring a single dimension, for example, like physical activity, fatigue, sexual function, or multi-dimensional tools, which are most of the case of patient-reported outcomes questionnaires in quality of life. And this is really important to really be sure to capture all the dimensions that are important to the patient. Why should we measure the perception of patient in clinical trials? Now, changes in therapeutic targets are growing in chronic disease, and in HIV specifically, we are in the situation that we cannot cure for the moment the HIV, but at the same time, the efficacy of all different treatment is very similar and it's very good. So it's really quality of life or other patient-reported outcomes that can make the difference between the treatment strategies. So why it is important to measure patient-reported outcomes? The difference between objective and subjective is important. Also, it could be considered that subjective measures have less value. It is very important because it brings additional information. This slide shows the differences when we measure the exercise test in a good condition in hospital versus a real life condition, and the correlation is just 0.4 points, meaning that we are not measuring the same concept. Another reason why to measure patient-reported outcomes is the weak correlation between clinician perception and patient perception. This example is from irritable bowel syndrome, and it shows when the pain intensity in the patients grow up, the clinicians have tendency to underestimate the pain of the patient. And the situation is the same in HIV trials. So most of the time in the trials, we will have investigator or doctor reported symptoms. However, when we will look to the patient reported symptoms, we will have much more severe or much more information. So this information might be more of value. When we do a study, how to choose a patient-reported outcome questionnaire, we really should think about use to existing and validated questionnaire. And maybe the first question will be, should we use generic or specific? We should check that all relevant and important concepts are captured, because to develop a new questionnaire is really long and rigorous. Unfortunately, if you ask a single item about quality of life globally, how do you rate your quality of life at this moment, bad or good, you will not capture the complexity of quality of life. This is an example, not in HIV, but it's very similar. This is in irritable bowel syndrome. If we should choose generic questionnaire or specific questionnaire. Irritable bowel syndrome is not only an abdominal pain, but it's also sleep impairment, use of hypnotics, diet restrictions. So if we use SF36, we will not have dimensions or items that are able to capture these differences. However, if we look to this FDQL specific questionnaire, we can see there are questions about sleep, diet, abdominal discomfort. So logically, you will choose the questionnaire. Unfortunately, I have to say, we still see in many trials use of generic tools like SF12, SF36 without not showing any differences and concluding there is no difference quality of life. So we really should stop use this generic questionnaire, especially if we want to show the small and specific differences. So which variables impact on quality of life in HIV in general? Mostly it's either HIV or treatment complications. It could be diarrhea. We still have many patients that have lipodystrophy since many years, although we don't have, or we have few these new treatments, but we have problems with vein gait and body image. We still have patients keeping the some neuropathy since many years. Fatigue is something that is really very frequent in HIV patients, or central nervous system effect like dizziness, drowsiness. Sleeping disorders are very frequent in HIV population. It's almost half of the population having sleeping disorders. Depression is very frequent. So it's many, and of course, many dimensions that still could be improved with HIV patients. Treatment regimen burden can be also different, either side effects, but it can be also bothering in everyday life patient. Gender is impacting quality of life in HIV, but also in other disease. Quality of life women is always worse. And also socioeconomic status can impact. But this is something that we are not focusing in this presentation, because we focus on health-related quality of life. So when you do a study, or when you analyze the study, you really should consider patient-reported outcomes the same seriousness that other endpoints. And what are the specific issues to this measure? You first check eligibility criteria. Is this PRO primary endpoint? Do we really know what we expect, like a set a minimal impairment on improvement, or a secondary endpoint? At what time and the frequency is important? Do we measure at baseline and 1 month, 3 months? The length of the trial is also important. modern site of administration. We should still try to be self-administered, assure the confidentiality for the patient and do it before giving the result to the patient. Also have a well-established process for data monitoring and quality assurance and procedures for how to prevent and how the missing data will be analyzed in the study. Now I will give you just 3 examples of differences that could be shown by patient-reported outcomes, and these different patient-reported outcomes in HIV. This is difference of satisfaction. This cabotegravir, and we can see that satisfaction, we can see big difference about 30%. Another example is from bictegravir/taf versus dolutegravir/taf in treatment-naive adults, and this is example of bothersome symptoms. We can see like fatigue, of loss of energy, or sleep problems, or feeling dizziness could be improved during the trial using patient-reported outcomes tools. And the last example is about quality of life. This is a French study of Optiprint comparing 3 therapy versus therapy with 5 molecules. Of course, you can see that quality of life in patient naive and start of the treatment, the quality of life in many dimensions is really bad at the start of the study beginning and improving in many dimensions. You can see still dimensions like stigma and health concerns, quality of life is still not very good. However, what we can see that physical health and body changes are not very impacted. But what is very important is this constant differences in quality of life in treatment impact dimensions, showing that when we take 5 molecules, the quality of life is really more bothered than if we take 3 therapy. And at the baseline, at the end of the study, when the control group joined the 3 therapy treatment, we can see the quality of life is the same in the both arms. Another example about quality of life in different dimensions, we can show also differences between countries and cultures. These circles show different dimension measured with ProQoL HIV specific questionnaire. This is, for example, stigma dimension, and different colors represent different country groups. We can see that, for example, in the black color, more we are in the middle, the worse quality of life is. And we can see this stigma in, for example, in Senegal, the quality of life was really, really impaired. Another example, what is really important is treatment impact dimension, and see that in different countries and in different healthcare system, the treatment impact dimension measured by these tools was very homogeneous. So it makes us confident when we measure quality of life. And to finish the presentation, now also electronic assessment, electronic patient-reported outcomes is important. It has several benefits. We have less missing data. We know at which time the patient filled the questionnaire. However, again, this questionnaire should be validated cytometrically when we want to be confident in the result. Thank you.
Thank you very much, Martin, for that very interesting presentation. And I look forward to having a discussion with you in the question period. Our next speaker is Dr. Romain Palich. Dr. Palich is an HIV clinician at the Petit-Salpêtrière Hospital in Paris. He focuses on antiretroviral therapies, HIV reservoir resistance, and cancer in HIV patients, as well as PrEP. So a pretty encompassing portfolio. He's a member of the ANRS, and his research includes virology, epidemiology, and social sciences. And Dr. Palich is going to present a clinical case involving cancer, archive resistance mutations, and antiretroviral therapy adjustments. Welcome, Dr. Palich.
Good morning, everyone. I'm very happy to have the opportunity to participate to this session. I was requested to present a clinical case, and I've decided to discuss about past resistance mutations and ART optimization in one HIV-infected patient with cancer. This man is a 65-year-old man. He is costume designer for theater at La Comédie Française. He is married with a HIV-negative man. His HIV infection was diagnosed in 1994 and he is treated by ART since 1996. Before the beginning of the treatment, his HIV viral load was approximately 100,000 copy per ml and his CD4 nadir was 180. He had never presented opportunistic infection. He is currently on etravirine plus raltegravir once daily and his HIV viral load is undetectable. Here you can see his virological history with the initiation of ART in 1996 by zidovudine plus didanosine. He continued to present a viral replication until 2005, so during 9 years despite his treatment, and from 2005 he has achieved an undetectable viral load. When you see him at hospital during a routine visit, he reports a clear deterioration of his general condition with a weight loss of 8 kilograms for 6 months with anorexia and asthenia. He had a chronic cough with dirty sputum and he reports an intermittent macroscopic hematuria. His biological tests show an anemia with hemoglobin at 9.4, an acute renal failure with plasma creatinine at 160, and a moderate inflammatory syndrome with CRP at 31. So you give him a prescription for a CT scan and for a bladder ultrasound. The CT scan shows bilateral emphysema, but no lesion suspicious of cancer. By contrast, the bladder ultrasound shows a big mass on the posterior side of the bladder with a dense vascularization, and as a consequence, you refer the patients to an urologist. A tumor resection was performed by endoscopy, and the histopathology examination shows a high-grade papillary urothelial carcinoma with necrosis infiltrating the muscularis. So the tumor is classified as a T2 high-grade infiltrating bladder carcinoma. And in France, we have a national network and working group called CancerVie. And this group provides a meeting, a multidisciplinary committee every 2 weeks to discuss cases of cancer in HIV-infected people. This committee provides recommendations for cancer management and ART adjustment regarding potential drug-drug interactions. For this patient, the committee recommended a neoadjuvant chemotherapy by methotrexate, vinblastine, adriamycin, and cisplatin. And the recommendation was also to stop etravirine because an interaction with chemotherapy. Antineoplastic and antiretroviral drugs share metabolic pathways, especially cytochrome P450, which can generate drug-drug interactions. Etravirine strongly induces cytochrome P450, and the risk is the inefficacy of the antineoplastic treatment. By contrast, boosters like ritonavir or cobicistat inhibit cytochrome P450, and the risk in this case is a significant increase in concentrations of antineoplastic drugs with a risk of severe side effects. In much less frequent cases, it's the cancer treatment that can modify the concentrations of ART with a risk of virological failure. On the right, the table summarizes the drug-drug interaction between ART and chemotherapies, and you can see in purple that the main interactions are due to boosted PI or boosted elvitagravir because of ritonavir or cobicistat, and in blue due to NNRTI, except for rilpivirine and doravirine. So back to our patient, we have to change his anti-HIV treatment to remove etravirine. The first element we have to know is the therapeutic history. As you can see, he has presented a sustained viral replication in the past on NRTI, PI, and NNRTI, suggesting the existence and the accumulation of resistance mutations on the RT and the protease genes. 2 resistance genotypes were performed from blood plasma on 2002 and 2005. Here is the result of the cumulated HIV-RNA genotype from these 2 genotypes. He has several mutations on the RT gene, including K65R and M184V mutation, conferring resistance to all NRTI, including tenofovir, and all NNRTI, except for etravirine and doravirine. There was no impact of mutations on the sensitivity to PI, and the integrase gene was not sequenced, but these patients did not experience viral replication on anti-integrase, so we can hypothesize that he has no resistance mutations to anti-integrase. Now, the question is it necessary, interesting to have a resistance genotype from HIV DNA after 15 years of undetectability to know if the mutation existing on the HIV RNA genotypes of the past are still present in the HIV reservoir? Of course, we have carried out this HIV DNA genotype, but before the findings, we can have a look on data published in the literature about the performance of HIV DNA genotype. There are several studies having compared the resistance mutations found on genotypes from HIV RNA and DNA in the context of viral suppression. For example, this study conducted by Constance Delogère has demonstrated that the number of mutations was always lower on DNA genotypes in comparison with RNA genotypes, whatever the treatment studied on this slide, NRTI and PI. The second study conducted by Marc Virdon had the same conclusion. So today, most teams agree that in clinical practice, it's more useful to have historical RNA genotypes. But if RNA genotypes are not available, a DNA genotype could be an alternative. Indeed, DNA genotypes seems to have a good positive predictive value when compared to past RNA sequencing, but negative results from PBMC must be interpreted with caution. In other words, the fear is not to detect mutations from the past due to lack of sensitivity of the DNA genotype. However, another explanation could be these mutations are not detected in HIV DNA because of a real occurrence of the mutation after 5, 10, or 15 years of undetectability in HIV reservoir. At the top of the screen, you can see again the result of the cumulated HIV RNA genotype, and at the bottom of the screen, you can see the result of the DNA genotype. Almost all the resistance mutations have disappeared on the RT gene, and if we take account only this genotype, the HIV strain of this patient is fully sensitive to all antiretrovirals, including NRTI and NNRTI. This case illustrates what we said just before. And the question is, should we trust past RNA genotypes or current DNA genotype? This question is very important to patients like this patient who absolutely need a change of heart despite numerous virological failures in the past. To answer this question, it's interesting to have a look on this recent study having demonstrated the progressive decrease in the resistance mutations in HIV DNA over time. 25 patients were included with at least 5 years of viral suppression, with at least 1 mutation associated with NRTI or NNRTI resistance on a past HIV-RNA genotype and with no therapeutic pressure, so with no NRTI or NNRTI for at least 5 years. New generation sequencing was performed every year during the last 5 years, and the study shows the stability of HIV DNA over time, the clearance of 72% of mutation at the last point, and the progressive decrease in the proportion of minority variants with resistance. So this study is in favor of the clearance of resistance mutations in HIV reservoir in patients with sustained viral suppression, which could allow the recycling of antiretrovirals despite resistance acquired in the past. So what we can do for this patient? In this context, we need ART able to maintain the viral suppression, of course, without nephrotoxicity and without drug-drug interaction with chemotherapy. So can we give taf-FTC bictegravir, abacavir, 3TC plus raltegravir, boosted darunavir plus raltegravir, dolutegravir rilpivirine, dolutegravir raltegravir, dolutegravir or dolutegravir plus lamivudine? We decided not to propose taf-FTC BIC because of the past resistance to tenofovir and lamivudine. We decided not to propose abacavir 3TC plus raltegravir because of the past resistance to abacavir and lamivudine. It was not possible to give boosted PI due to the interaction between ritonavir and chemotherapies. We decided not to propose dolutegravir rilpivirine because of the past resistance to rilpivirine. In this patient, we chose not to take account the result of the DNA genotype because we had alternatives, and we hesitated between doravirine raltegravir and doravirine dolutegravir, although there is no data on the efficacy of these two dual therapies. For information, there are 2 ongoing clinical trials studying doravirine raltegravir and doravirine dolutegravir. Finally, we chose doravirine plus dolutegravir. Another option could have been dolutegravir lamivudine despite the past resistance to 3TC. Indeed, there is some evidence of efficacy of this dual therapy despite a historical M184V mutation. The MobiDeep experience has demonstrated that lamivudine, in association with darunavir ritonavir, was able to maintain the virological success, and that was not the case in the absence of lamivudine in patients who had a M184V mutation in the past in 97% of cases. More recently, that's the slide, our Italian colleagues have showed in a retrospective cohort that this mutation had no significant impact on virological control in patients on 3TC-based dual therapies, including 24 patients on dolutegravir lamivudine 3 years after switch. However, the number of blips was significantly higher in patients with M184V mutation in comparison with others. Also, the French dolulam experience has shown a sustained virological efficacy of dolutegravir 3TC in 10 patients with previous M184V mutation. So overall, these studies suggest that dolutegravir 3TC could be a good option for patients with previous virological failure on lamivudine. However, in this patient, we did not choose dolutegravir lamivudine because we had other alternatives, and we chose doravirine plus dolutegravir. 6 months after the switch, the plasma viral load remained below 50 copies per ml, and for the cancer treatment, the patient received 4 cycles of methotrexate, vinblastine, adriamycin, and cisplatin, and then was operated with a complete cystectomy. To conclude, I would like to give you some key points from this clinical case. Cancer is now a major concern in aging HIV-infected people. Anti-neoplastic treatment is always the priority, and there is no restriction, no contraindication due to HIV status. So HIV treatment ART must be adapted to avoid drug-drug interactions. ritonavir and cobicistat and the first generation NNRTIs frequently generate interactions. Past virological failures and the past acquired resistance mutations complicate the modification of ART. And finally, HIV-DNA genotype may be useful in patients with sustained virological suppression and could help to recycle drugs in case of previous resistance. Thank you very much for your attention, and I would like to thank all my colleagues of the Conservi, and Oncovi study group. Thank you.
Thank you very much, Dr. Palich, for that very interesting case. I would like to remind all of you attending this session to submit your questions when they pop into your mind, so you don't forget to ask them and we have a chance to go through them and make sure we're not duplicating, so that we get through everybody's questions in the question and answer period. We now move on to abstract-driven presentations, and we have 3 presentations in this session. The first is by Dr. Anne-Geneviève Marcelin from the University of Sorbonne in France, and she'll be speaking about factors associated with the emergence of resistance mutation in patients failing dual or triple integrase inhibitor-based regimens in a French national study. That'll be followed by Dr. Ali C. Mohammed, who is laboratory head at the University Center Hospital in Dijon, who will be speaking about HIV-DNA pro-resistance genotyping based on Illumina sequencing as a decisional marker for antiretroviral therapy optimization in clinical practice, added value, gaps, and future directions. And finally, a presentation by Dr. Roberta Gagliardini from the National Institute of Infectious Diseases in Rome on high efficacy after switching to integrase strand transfer inhibitors in people living with HIV with undetectable viremia and past virologic failure and or resistance.
Hello, I am pleased to present you our study on factors associated with the emergence of resistance mutations in patients failing dual or triple integrase inhibitor-based regimen in a French national survey. This study was conducted on behalf of the INRS Virology network. Here are my disclosures. For approximately 20 years, 3-drug regimens have been the concept of antiretroviral therapy. However, considering the lifelong art and the need to decrease the potential adverse effects of drug exposure, some alternative strategies have been proposed, especially 2-drug regimen. It has been shown a similar proportion of virological HIV suppression between 2-drug and 3-drug regimen for patients with an integrase inhibitor-based regimen in some clinical randomized trials. It has been shown for already suppressed patients with dolutegravir and lamivudine, dolutegravir and rilpivirine, cabotegravir and rilpivirine. It has been shown also in naive patients with dolutegravir and lamivudine. In these trials, there were very few virological failures and very few resistance mutations in case of virological failure. However, there is a need to get more data about resistance to integrase inhibitor in the context of 2-drug versus 3-drug regimen in clinical practice. So the aim of our study was to compare in a multi-center observational retrospective study on failing HIV patients receiving a 2-drug or 3-drug regimen, including an integrase inhibitor, the presence of at least one integrase resistance mutations, and baseline variable associated to the occurrence of at least one integrase mutations, in particular to distinguish between the effect of the following factors: receiving a 2-drug or 3-drug regimen, the genotypic sensitivity score associated to the other drugs and the integrase inhibitor in the regimen, and the integrase inhibitor received. The inclusion criteria were HIV-infected patients followed in a clinical site within the INRS network between 2014 and 2019 in France, failing an integrase-containing regimen with raltegravir, elvitegravir, and dolutegravir, and the virological failure was defined as 2 consecutive HIV viral load above 50 copies per ml. First, an univariate analysis was performed to study the associated factor, and in the multivariate analysis, only variables with a p-value below 0.1 were retained for building the final multivariate model using a stepwise selection. Integrase sequences were determined on plasma failure in each participating laboratory, and this is the list of the integrase-associated resistance mutations used in the study. Resistance was interpreted using the last INRS algorithm, and the genotypic sensitivity score of the current regimen without the integrase inhibitor was calculated as follows: 1 for susceptible, 0.5 for intermediate, and 0 for resistance. We analyzed 1,104 patients, 207 in the Duratherapy group, and 897 patients in the triple therapy group. There were some differences between the two groups. Indeed, patients treated by a 2-drug regimen were older, HIV infected for a longer time, receiving an integrase inhibitor for a longer time. They had a higher CD4 cell count and a lower viral load at failure. In addition, in the 2-drug regimen, there were less naive patients and more patients receiving an integrase inhibitor for the first time. In the 2-drug regimen group, patients were receiving raltegravir in 70% of cases and dolutegravir in 30% of cases. No patients were treated by elvitegravir. And in the triple therapy group, patients were receiving raltegravir, elvitegravir, and dolutegravir in 30% of cases approximately. In the 2-drug regimen group, the associated treatment to integrase inhibitor was 1 PI in 53% of cases and 1 NNRTI in 35% of cases. In the 3-drug regimen group, the associated treatment to integrase inhibitor was mainly 2 NRTIs. Among the failing patients, 42 patients of them had viruses harboring at least one integrase-resistant mutation. 26 had 1 mutation, 10% had 2 mutations, 4% had 3 mutations, and 2% had 4 and more mutations. Overall, the N155 and the L74 mutations are the most commonly observed mutations, with 15% and 14% of cases, respectively. As you can see, overall, patients failing raltegravir and elvitegravir had viruses with a higher level of integrase inhibitor predicted genotypic resistance at failure than patients failing dolutegravir. Here are the results of the statistical analysis showing the factors associated with the occurrence of at least one integrase resistance associated mutation. Although 2-drug regimen was associated with a higher risk of emergence of integrase resistance associated mutations in univariate analysis, the factors that remained associated in the multivariate analysis were a higher level of viral load at failure and the non-B subtypes with a higher risk of occurrence of at least one integrase mutation, a higher level of GSS, and patients receiving dolutegravir containing regimen with a lower risk of occurrence of at least one integrase resistant mutation. So in conclusion, this is a large cohort of patients failing an integrase-based regimen followed in hospital clinical care. Among patients failing an integrase-based regimen, 42% harbored viruses with at least one integrase-resistant mutation. That is similar to some previously published studies. The most frequent resistance mutations observed were the 155 and the 74 mutations. And overall, the level of integrase genotypic resistance was lower for patients failing dolutegravir than patients failing raltegravir or elvitegravir. Finally, considering the occurrence of at least one integrase resistance mutation at failure, the multivariate analysis showed a higher risk with a higher level of viral load at failure, a non-B subtype, and a lower risk with a higher level of GSS and for patients receiving dolutegravir. There was no difference between 2-drug regimen and 3-drug regimen. I would like to thank all the INRS resistant group and especially the coordination committee. And I would like also to thank Dr. Kata-Soulier for preparing these slides. Thank you also to all the INRS resistant group. Thank you for your attention.
Good afternoon. I thank the organizers of the meeting for these invitations, and I'm delighted to present you our results. No conflict of interest with the subject. The peripheral blood molecular cells, PBMC, include archived drug resistance mutation that reflect previous treatment regimen failure. Highly diversified drug resistance mutation in proviral DNA lead to their inconsistent detection by Sanger technology. Ultra-deep sequencing is more prone technology to detect minor variants. Also, ultra-deep sequencing of proviral DNA may be an interesting alternative to detect HIV drug resistance mutation in situations where RNA genotyping by Sanger sequencing is not informative. However, its implementation in clinical practice has not yet been validated. Our objective is to evaluate the pertinence of ultra-deep sequencing to explore archived drug resistance mutation in comparison to cumulative HIV-RNA genotyping performed by Sanger approach. To address answer about hypothetic integration of DNA ultra-deep sequencing as a decisional marker in clinical practice. 169 HIV-infected patients experiencing several lines of antiretroviral therapy, and among them, 16 naive patients recently diagnosed were included. For ultra-deep of HIV-DNA, samples used in this study were emanated from routine HIV-DNA genotyping resistant testing. Ultra-deep sequencing was performed on HIV protease and ribosome tryptase fragments from PCR products amplified according to the NRS recommended procedures. For each DNA sample, PCR was performed in triplicate in the first PCR step. Paired end indexed libraries for MySeq using the NextEra DNA sample preparation kit from Illumina. The generated reads were then processed in the bioinformatics pipeline VIGU developed in-house by a bioinformatics team from genetic department. Sequencing products are then analyzed using a bioinformatics pipe called VIGU, which allows for each mutation to calculate the background noise, to generate consensus sequence, to perform a clustering to find similarity and identify clusters. Reads with high quality are considered and aligned against a reference sequence. Reads with a stop codon were excluded. Finally, HIV-DNA drug resistance mutation with ampersand frequency were then considered. For the period from April 2015 to June 2018, 169 genotypes tests were performed. In 21 cases, 2 tests were performed in the same period and were not included in the study. Of the remaining, 37 had missing data. In the end, the study concerns 111. The main characteristics of the study population are: there are 29% of women, 60% of patients are in CDC clinical stage B or C, about 40% of patients are on a therapeutic regimen including an integrase inhibitor. The main virological characteristics of the study population are: about 82% of patients have at least one RNA genotype. 72% of patients had the DNA genotype by Sanger methods. In over 70% of cases, subtype B were found. At the time of sampling, 58% of patients were in virological success. For greater clarity, we have assigned arbitrarily a score to the resistance mutation. 0 score for mutations associated with ApoB. Score 1 for secondary mutation, which by themselves do not induce resistance. Score 2 for mutations that induce resistance to a single antiretroviral molecule. Score 3 for mutations that induce resistance to 2 or more antiretroviral molecules. The global illustration of comparison between two assays show that what is in red corresponds to the common mutations detected by the compared two tests. What is in gray corresponds to mutations detected by only one of the two tests. Figures A, B, C are about all mutations irrespective of their score. Figures D, E, and F focuses on drug resistance mutation with 2 and 3 assigned score. Globally, ultra-deep DNA sequencing and cumulative RNA genotype were more prone to detect drug resistance mutation than Sanger DNA. Drug resistance mutation detected only by Illumina in DNA are at very low frequencies when compared to either cumulative RNA or Sanger DNA. These observations raise questions about the relevance of these resistance mutations at low level detected only by ultra-deep sequencing in viral DNA, and encourage to characterize the cofactors that can modulate the frequency of drug resistance mutation archiving in the DNA compartment. We found that drug resistance mutations, all mutations, are detected at the high level in ultra-deep DNA sequencing when it's detected more recently in RNA, either for all mutations, irrespective of assigned score, or for drug resistance mutations with 2 and 3 score. This is also true irrespective of antiretroviral classes, either an RTI or an NRTI. These observations suggest that there is a possible clearance of drug resistance mutations in the DNA compartment, and in the next step, we wanted to characterize factors that could modulate this clearance. Our working hypothesis is that the duration of undetectability favors the clearance of drug resistance mutations within the DNA compartment. Between two cases with different undetectability durations, we expected to have a fewer variants archived in case 1 with a long time of undetectability compared to more resistance variants archived in case 2 with a short time of undetectability. As illustrated for drug resistance mutations with 2 and 3 score, we found that the longer duration of undetectability was inversely correlated to the magnitude detection of drug resistance mutations in the DNA compartment by ultra-deep sequencing. However, in certain situations, the duration of undetectability does not explain everything, so we tried to characterize other factors that could also modulate the level of archiving. Our working hypothesis is that the duration of replication under selection pressure favors the level of archiving between two cases according to time replication. We would expect to have less resistant variant in case 1 with a short time replication under selection pressure compared to case 2 with a long time replication under selection pressure. As we can see, the treatment failure durations modulate positively the level of drug resistance mutations archiving. This is true for an RTI and as easily illustrated with 184V mutations, since it's only selected by 3TC and FTC, we see a good correlation between duration failure, months, and the frequency of drug resistance mutation detected by Illumina in DNA. Not shown, but the same correlation was also observed with an RTI. This case illustrates the importance to test a large amount of DNA, profile of cumulative RNA genotypes corresponding to 7 genotypes performed between 1999 and 2008. At least 2 PBMC fractions were tested separately and as a pool, in duplicate by Illumina. As you can see, drug resistance mutations involved in the major resistance to an RTI were not detected in both fractions. 181C not detected in fraction 1, and 101 and 190 not detected in fraction 2. Interestingly, no drug resistance mutations were missed when the two fractions were pooled. The last point concerns the possibility of using DNA genotyping by ultra-deep sequencing in clinical practice. At baseline, corresponding to time where ultra-deep sequencing DNA were performed, we can observe a weak difference in the mean GSS to antiretroviral taken at this time among patients with or without virological success. We also looked at 12 months follow-up the response to antiretroviral therapy according to the GSS for the ultra-deep sequencing DNA test and the cumulative RNA. We have observed that in all cases, ultra-deep DNA does as well as cumulative RNA to predict virological success when the GSS greater than or equal to 2. Also, both assays could similarly predict with the same proportion virological failure when GSS is less than 2. For the conclusion, our strategy, based on a large amount of DNA included in PCR assays, was highly sensitive and may allow us to deal with the fluctuation of archived drug resistance mutation in the DNA compartment. As shown, the magnitude of archived drug resistance mutation are affected by undetectability duration and the time duration of virological failure. In real life, in cases where cumulative RNA is not available, DNA genotyping by ultra-deep sequencing may be helpful. For more data is needed to assess the predictive value of ultra-deep sequencing DNA in clinical practice. Finally, I would like to thank the patients, institutional support, and all the colleagues with whom I collaborate daily. Thank you for your attention.
Good evening to everyone, and thank you to the organizers for having selected this abstract about switching to INSTI regimens in patients with undetectable viremia and past virological failure and/or resistance. About 12% of people living with HIV have previous virological failure, according to Italian data. Data on optimization of antiretroviral therapy with INSTI regimens are limited, and current guidelines do not specifically address this issue. They only provide some general rules like avoid to switch to lower genetic barrier regimens, consider always the cumulative genotype, the tolerability and toxicity issues, while the NRTI usage in the context of previous resistance is still debated. Raltegravir-based regimens resulted to be less effective than PI in patients with previous virological failure, while for elvitegravir-based regimens we have some mixed results in the same context, and high virological efficacy was demonstrated with dolutegravir plus 2 NRTI in patients with residual NRTI activity, and also with bictegravir, tenofovir alafenamide, and FTC in patients virologically suppressed but with previous NRTI resistances. Few data are available for the other INSTI-based options. This is a retrospective multicenter study conducted in Italy that included patients who were more than 18 years old, are treated with HIV-RNA below 50 copies at baseline, who had at least a previous virological failure followed by at least one genotype, and that had switched to an INSTI-containing regimen. Primary endpoint of this study was the viral rebound, defined as confirmed HIV-RNA over 50 copies per milliliter. We analyzed the incidence ratio of viral rebound, estimated according to GSS and according to high resistance level to NRTI, that was defined as having the K65 mutation, having at least 3 TAM, or having the insertion T69 at the cumulative genotype. We use the inverse probability weighted Cox regression to estimate causal hazard ratio of viral rebound, adjusting for the main confounders that were CD4 cells count at nadir, mode of HIV transmission, duration of viral suppression, and number of previous genotype. The previous virological failure was defined as 2 consecutive viral load over 50 copies or 1 viral load over 1,000 copies, and the baseline for the analysis was the date of the switch to the INSTI regimen under viral suppression. The regimens started at switch were categorized in 4 groups: 2 NRTI plus first generation INSTI, 2 NRTI plus first generation INSTI, or INSTI plus PI boosted, or INSTI plus NRTI or NNRTI. In this slide, there are the main characteristics of our population. We found 654 patients respecting inclusion criteria. Regimens started at baseline were 2 NRTI plus INSTI of first generation in 33% of patients, 2 NRTI plus dolutegravir in 26% of patients, and INSTI plus a PI, a booster PI, in 21% of patients, and INSTI plus NNRTI or NRTI in 19% of patients. As we can see this is a quite heavily treated population characterized by 21 years of HIV infection, 17 years of ART exposure, CD4 cells count at nadir was of 116 cells. Patients who switched to dual therapy composed of INSTI plus NRTI or NRTI were characterized by a longer time of HIV suppression, while patients who started a triple regimen based on first generation INSTI were more frequently co-infected with hepatitis C and more frequently showed intravenous drug use as mode of HIV infection. In this slide, we have the GSS and resistance level to NRTI in the different groups. We don't have time to go on details, but on the left, we have the GSS in the overall population. 33% of patients had a GSS below 2, and 67% of them had a GSS equal or superior to 2. Incidence rate of viral rebound was comparable throughout all these stratifications by GSS and by resistance level to NRTI, and vary between 8 and 9 per 100 person-year follow-up. Patients in first-generation INSTI-containing regimens had an incidence rate of viral rebound of 10.1 per 100 person-year follow-up, and those in second-generation INSTI-containing regimens had an incidence rate of 6.5 per 100 person-year follow-up. In this table, we can see crude and adjusted hazard ratios of the risk of viral rebound from fitting a weighted Cox regression model according to GSS, and this model is adjusted for CD4 cells count at nadir, duration of viral suppression, number of previous genotypes, and mode of HIV transmission. By multivariate analysis, patients with GSS equal or more than 2 had a lower risk of viral rebound. The adjusted hazard ratio is of 0.60, the 95% confidence interval of 0.31 to 1.14. Then those with GSS below 2, but this result is not statistically significant in the overall population analysis, even though we reach the statistical significance for the INSTI plus NRTI or NRTI group. Similar results at Cox regression analysis were obtained also with the other definition of resistance. In fact, by multivariate analysis, patients with higher resistance had higher hazard ratio of viral rebound than those with no resistance or with low resistance, but the results are not statistically significant. So this study presents some limitations due to the unmeasured confounding and due to the fact that we still did not collect any data about bictegravir in this study, but also some strengths due to the large sample size and the real-life data. So to conclude, patients with GSS equal or more than 2 had a lower risk of viral rebound than those with GSS below 2, but not statistically significant in the overall population analysis. In general, after switching during virological suppression guided by genotype, all the INSTI regimens maintained high rate of virological success, even in heavily treatment-experienced patients and even with low GSS and or pre-existing NRTI resistance. I would like to thank all of you for your attention and all the study group that is here reported. Thank you.
all the time, what we call floor or ceiling effect. And in that case, we see already in the validation of the questionnaire that this everybody's answering in the end. We usually don't keep the answer. We want to keep the items that have homogeneous distribution of the items. Then there is another way how to control it. For example, if we do some study and the objective of the study would be some improvement of quality of life or improvement of the symptom of the patients, it could be already the criteria of inclusion. For example, this is often the endpoint of adherence. We have in clinical trials, we always look to the adherence, but most of the time it's so high, it's over 90%, that we are not able to show the difference because it's already too high. So the place for the change over time or difference between groups is very small in that case. And lastly, I would like to complete, because this question is related to the interpretations of the score in the clinical trials on the study. And this is very important because most of the time we will see very small changes in the scores of quality of life that could be statistically significant. So what is important also, the same thing that for other endpoints to set up the same rules and to try to have also clinical significance of the difference, or to set up prior to the study what would be clinically minimal important change or difference between the groups.
Great. Thank you very much for that. Our next question is for Dr. Palich, and I think it's more of a comment than a question, but I'll let you address it. The question is, although the resistance in the reservoir may decrease over time, we cannot predict what has actually gone by plasma DNA genotyping. Reactivation depends on antigen stimuli, and we can't map drug resistance to the CD4 cell antigen. I don't think it's a good idea to ignore prior plasma genotypic resistance, even if DNA genotype shows wild type. I'll ask you if you'd like to comment on that.
Yes, thank you for this comment. I understand the reluctance to use DNA genotype to guide the adjustment of ART. I don't think that DNA genotype can replace the analysis of past RNA genotypes. However, in some patients with many resistance mutations, we can be in a therapeutic dead end, and maybe the recycling of drugs could be an alternative to explore. And sometimes there are no available RNA genotypes. So I did not say it's a safe option, but I think we have some interesting virological data on dynamics of HIV reservoir in patients with very sustained viral suppression. And I think it would be very interesting to design a trial to assess the reuse of ART in this context.
Thank you. Next question is for Dr. Marcelin. Since two-drug regimens was by far mostly integrase and protease inhibitor, how comfortable are you generalizing to all two-drug regimens in your conclusion?
Yeah, thank you for this this point. This is a good point. Indeed, in our study, this is a retrospective study with many different regimens. So and a large proportion of patients were treated by boosted PI in addition to the Integrase inhibitor with the dual drug regimen. So yes, I agree. It's not possible to generalize to all drug regimen, but the statistical analysis showed no difference. So, but I totally agree that not all the two-drug regimen are equivalent, especially regarding the emergence of the risk of emergence of drug resistance. So maybe we could point that in the discussion of the future publication.
Great, thank you very much. To Dr. C. Mohammed, I really like your hypothesis, really like hypothesis 2. How would you also take into consideration resistance and the cells that contain these proviruses and specific immune responses to pathogens, if resistance in a CMV reactive cell may be maintained more than a less common pathogen? I think you're on mute, Dr. C. Mohammed.
Yes, thank you for your questions. For our second hypothesis, we just correlate between past duration failures and the magnitude of drug resistance mutation found in the prevalent DNA. It's correlated to the time of replication under pressure selection. But we cannot exclude that patients have not taken these drugs. Just we have just taken in account the prescription of drugs and the viral replication. So it's clearly correlated between for 2 mutations for 103 for an NRTI and for 184 for an FTI. Other mutations like thymidine-associated mutation could not correlate to the time of virological failures. Thank you.
Thank you very much. Question for the group, and anyone who wants to chime in is more than welcome, is we're certainly entering a world now where cabotegravir and Cabenuva is coming up pretty near. We actually have it now in Canada, but there seems to be some debate on whether or not cabotegravir is a first or a second generation integrase inhibitor based on the resistant profiles that we know so far. Would anyone like to comment on whether or not they feel it's a first or a second generation?
Maybe I can comment. I think if we look at the structure of cabotegravir, it's very similar to dolutegravir. So we can expect that cabotegravir could be considered as a second generation integrase inhibitor. However, there were some other considerations such as the combination with rilpivirine, that is an NRTI with a low genetic barrier. So I think we, beside the genetic barrier of a particular molecule, we have to think about the overall genetic barrier of the combination. So that's my point of view.
Thank you. And to that as well, what fold change would you recommend to be considered to use dolutegravir BID in a resistant patient as opposed to once a day? Now, for example, we do have Cabenuva now here in Canada. So I have a patient who developed the E92Q on elvitegravir-based regimen, and he has a 1.5 change to dolutegravir. Would that be enough to warrant dolutegravir once a day, or should he be placed on dolutegravir twice a day? And the reason I'm asking that is because what we did is we put him on Biktarvy, darunavir, cobicistat. And I know he's going to come back and say, you know, in 6 months, can I switch to the injectable Cabenuva? for compliance. And so how comfortable would you be to do that, knowing that he's got only one integrase mutation?
It's a difficult question. Yes, it's a very difficult question because maybe I should prefer dolutegravir BID for this kind of patient with prior integrase resistance mutation. So we have no data about the efficacy of cabotegravir in this kind of patient. So maybe you could try, but to ask to the patient to come very shortly after the initiation to follow very carefully the viral load.
Thank you, and I apologize for the tough question, but I think it's a question we're going to get asked more and more, because a lot of patients are going to want to go on the injectable, and they may not be, eligible for it. For reasons.
Yeah, and I would be very careful about the profile of the patient if there are all the history. If he had, for example, the previous exposure to NNRTI, I would totally avoid the combination with cabotegravir plus rilpivirine, even if there was no apparent virological failure under previous regimen with NNRTIs.
Thank you. We have another question. I'm not sure who it's addressed to. I believe it's Dr. C. Mohammed. In the case where there's an unusual deletion that would lead to frame shift and loss of function in the sequencing of HIV-1 RNA in an otherwise clear sequencing signal, what would be your verdict? I.e., if the deletion is true, how does the virus carry out its infection?
It's not about resistance. It's about defective. I'm not sure that I catch exactly the questions. It's about defective virus or about?
I'm honestly not sure. I'm not sure myself, to be honest with you. The question was, how does the virus carry out its infection in the presence of an unusual deletion?
Is it a lethal deletion or?
Ask the individual who posed the question to send another chat to clarify, so make sure the question is answered.
If it's a lethal deletion, it's produced a defective virus.
Yeah, I'll ask the individual who submitted it to clarify, so that we make sure we answer their question. In the meantime, another question for Dr. Palich. It's interesting that when HIV started, we talked about treating HIV as an oncology model. However, treating HIV is nothing like an oncology model. Oncology, chemotherapy, drugs are dosed based on patient body weight, surface area, tumor burden, all those kind of things. I wonder going forward if we can minimize some of the toxicity if we were to look at HIV medications by changing their doses. And it's probably more of a PK question, but cancer serves as a model. As people are undetectable, do they really need the same dose of HIV antiretroviral medication to treat a viral load of 500,000 versus a viral load of undetectable and to maintain it? I'm just curious to your thoughts on that.
Yes, to my knowledge, the rule is to give the same treatment for people with cancer if there are HIV infected people or not. So there is no adjustment of dose of chemotherapies.
Yeah, no, there is no
drug-drug interaction, of course.
I'm curious if you think we should look at studies, especially in people receiving chemotherapy, in terms of dose adjusting, not just changing regimens, because we're changing an effective regimen to another hopefully effective regimen.
Yes, but in the absence of drug-drug interaction, there is no reason to adjust the dose of chemotherapies.
Okay, thank you. The individual has not resubmitted their question that I sent to Dr. C. Mohammed, so I don't see any further questions. Does anybody have any parting comments before we move on to the next session? Well, if not, I'd like to thank each of you for your amazing presentations. I'd like to thank our audience for attending the session as well. I believe now there is a poster viewing session. Yes, which you can join online, and then tomorrow's program starts at 2 p.m. Central European time with resistance to long-acting antiretroviral medications. So I'd like to thank you all for attending. I wish you well. Stay safe, stay healthy, and take care of yourselves and your family. And thank you very much.
Thank you.
Thank you very much.
Bye.
Bye.
Bye-bye.